Presentation for the chest imaging from number 7, prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. This will be for the diaphragm. Of course, you know that the right hemidiaphragm is higher than the left. This is because of the liver. 90% of congenital diaphragmatic hernias are bucolic hernias, which are arising posterolaterally due to failure of the costal and vertebral portions of the diaphragm to fuse. Failure of the costal and vertebral portions of the diaphragm to fuse. These are more common on the left than on the right because of the protective effect of the liver posteriorly. So bucolic hernias is posterior and to the left. The foramen for what is located in the central tendon at T8 intervertebral disc level to the right of middle line. It is the foramen for the inferior vena cava. It is at the central tendon at the level of T8-9 intervertebral disc, right to the midline, right to the midline. The hiatus within fibers of the right crus contains the esophagus and vagus nerve. The hiatus within the fibers of the right crus contains the esophagus and vagus and is located at T10 vertebral body level. The hiatus at T12 L1 intervertebral disc level, just to the level of the left of the midline, contains 5 structures: aorta, azygos, hemiazygos, and thoracic duct. Sorry, four structures: aorta, azygos, hemiazygos, and thoracic duct. So to repeat again, for the inferior vena cava, it is opposite T8-9 space at the central tendon to the right. Then for the esophagus and vagus, again within the right crus, opposite T10, but those for the aorta, azygos, hemiazygos, and thoracic duct are to the left of the midline at the level of T12 L1, lower level. What are the contour abnormalities of the diaphragm? Pathologically, the most common are the eventration and hernias via the eventations and hernias, via bucolic or Morgani, or via an acquired diaphragmatic defect. So the hernias could be through foramen of bucolic, foramen of Morgani, and these are congenital, and acquired diaphragmatic defects, or due to eventration. The commonest is non-pathological diaphragmatic hump. The commonest is a non-pathological diaphragmatic hump. Rarely, tumor of the diaphragm, fibrosarcoma, is more common. Basal pleura of the basal pleural or parenchymal masses are indistinguishable. You cannot differentiate between pulmonary or pleural masses invading the diaphragm. This is difficult. So what is the most common malignant tumor to involve the diaphragm? It is fibrosarcoma. Name the 3 conditions that can appear as an abnormal diaphragmatic contour: hump, which is normal, hump, which is normal, non-pathological, eventration, but this is usually a smooth out one, bucolic and Morgani. These are the 3 conditions that can occur besides the famous diaphragmatic defect. What is eventration? Diffuse eventration is 90% on the left side, as the liver protects on the right side. The differential diagnosis of eventration is congenital herniation and diaphragmatic paralysis. In eventration, the muscle layers of the diaphragm is converted into a thin fibrous sheet and thus is able to be pushed up, while in forced inspiration the right copula or the healthy copula will be pushed down, and this is called paradoxical movement. It's similar to diaphragmatic paralysis. Similar in behavior to diaphragmatic paralysis, but the causes are different. Now come to diaphragmatic hernia, may be congenital, as we know, Bugdalic hernia, Morganae hernia. Bugdalic is usually posterior and to the left side, while Morganite is anterior, or it may be acquired diaphragmatic hernia like trauma. Esophageal hiatal hernia is another sort of hernia due to weakness. So the acquired are the esophageal hiatal hernia and the traumatic hiatal hernia, and the congenital are the foramen of Bugdalic and the foramen of Morganae. Then you can add the trauma. You can add the hump, which is a non-pathological condition. Name two types of congenital. So it is Bugdalic posterior, Morganae anterior. Name two types of acquired hernias. It is the esophageal hiatal hernia and trauma. Of course, esophageal hiatal hernia has two types. What is posterior? It is Bugdalic. What is anterior? It is Morganae. What is posterior? It is Bugdalic. And here mass at the left base of the left hemithorax, left base, posterior, it is a Bugdalic hernia. Because as we said, Bugdalic is a defect posterior, while Morganae is a defect anterior. Abnormal cardiac contour. Large, well-defined masses at the right cardiophrenic region. Could be omentum, could be bowel, could be liver, could be strands, fibrofatty tissue. Could be pericardial bed of fat or pericardial cyst, or foramen of Morganae hernia, as it is anterior. Again, lipoma, lymphoma. CT can exclude cysts and lymph nodes. Large, well-defined. This is a large, well-defined mass at the right cardiophrenic angle. The differential is big. It could be a pericardial bed of fat. It could be a foramen of Morganae hernia. Could be a cyst, lipoma, lymphoma. Of course, as the CT will exclude lymph nodes and cysts. And here it is foramen of Morganae hernia containing fat. Foramen of Morganae hernia containing fat and part of the liver. Again, foramen of Morganae hernia containing liver. Here it is. It's right anteromedial, right anteromedial containing liver tissue. Foramen of Morganae hernia. Rupture following vomiting, loss of lung volume on the left side, pleural fluid, lobulated, denoting pleurisy, and empyema, left lower lobe opacity, and free gas. So this is the sequelae of rupture of the esophagus following vomiting, Burhavi's syndrome. This is blunt diaphragmatic hernia, in which we can find the left pleural effusion, left basal opacity, upward displacement of the gastric air bubble, because of the defective diaphragm. The NGT inserted in the stomach is seen in an upward place in the lower part of the chest. Here it is. And there is left lower lobe athlexis. Mind you that in such cases we have two signs. On the left, the spleen may bulge into the defect and showing a waist, or the liver is bulging showing a waist, or the stomach is bulging showing a waist, and this is called the choral sign. This is blunt traumatic diaphragmatic hernia, best seen in reconstruction coronal and sagittal views by CT. Indistinct or elevated copula of the diaphragm, left lower opacity, gas containing viscous inside, barium or contrast containing viscous, pleural reaction, so bowel in the chest. The diaphragmatic defect may not be seen. On the right you can get liver, on the left you can see spleen, liver protruding into the diaphragm with what we call choral sign. That means that there is a waste of the stomach, waste of the spleen, waste of the liver if it is, and here is the waste of the stomach, waste in the stomach, at the region where the stomach is bulging above the ruptured diaphragm. Another sign for ruptured diaphragm is the incomplete crus. Incomplete crus or thickening of the crus or a muffling of the crus. This should be considered as another sign. Thank you.